Good evening, everyone. On behalf of the United States Spiritist Medical Association, I welcome all of you to this panel discussion that will focus on highlights of the webinars by Dr. Rosmarin, Dr. Drysdale, Dr. Koenig, and Dr. Moreira-Almeida, presented in the webinar series Spirituality and Mental Health earlier this year. I am Lino Rodrigues, and I will be the moderator for this panel discussion. I'm a physician and a member of the board of directors of the United States Spiritist Medical Association, that I refer to as SMA. Our panelists for tonight will be Dr. Rafael Rezende, PhD. He's an assistant professor of neurology at Brigham and Women's Hospital at the Harvard Medical School. Dr. Rezende is also a member of the SMA. Dr. Livia Uehara. Dr. Uehara has an MD degree and specializes in internal medicine and hematology, and is also the vice president of the SMA. The third panelist is Dr. Paulo Bispo, MD, who is an academic scientist with a PhD in infectious diseases and an assistant professor at the Harvard University. Dr. Bispo is also a member of the SMA. And Dr. Sonia Doi, MD, with a PhD specializing in endocrinology and 30 years of experience in medical research and teaching. Dr. Doi is the current president of the SMA. Before we get started with our program, I'd like to give a brief introduction for those who are not familiar with Spiritism and with the SMA. Spiritism is a science supported by empirical evidence and is a philosophy based on the moral teachings of Jesus. So it is a Christian faith. It is important to note that Spiritism is open to all beliefs and religions and has no discrimination of any kind. The main tenets of Spiritism include the existence of a supreme intelligence, the immortality of the soul, the plurality of existences or incarnation, the plurality of inhabited worlds, and the communication with spirits or mediumship. The SMA is a 501c3 nonprofit organization directed by Spiritist medical doctors. The purpose of the SMA is to improve clinical treatment outcomes by teaching about the influence of the spirit or soul in physical and mental health. SMA's vision is to advance spiritual care in routine clinical practice, and its mission is to educate healthcare professionals and support research on the impact of the spirit and soul in physical and mental health. You can support our cause by becoming a member. The link for membership is pasted in the chat box now. We want to hear from you during our discussion, so please send us your questions or comments and on each webinar via the chat box, and we'll relay them to our panelists. And with that, I'll invite Dr. Sonia Doi to say a prayer.
So at this moment, I invite all of you, if you feel comfortable, you can close your eyes and let's elevate our thoughts, letting go any feelings of resentments, any worries from our mind, so that we can connect to our divine creator, to the divine power of the universe, asking that our minds are illuminated, that our faith is strengthened, that we receive light and peace, and that we ourselves can emanate light, peace, and love to the whole universe, especially to our brothers and sisters who are involved in affliction. We ask the divine creator to bless us and bless all who are now with us, and that we all together are vibrating in harmony, and so be it. Thank you.
Thank you, Sonia. Now I'd like to invite our first panelist, Dr. Rafael Rezende, to share his insights on the webinar of Dr. David Rosmarin, entitled Spiritual Psychotherapy for Inpatient, Residential, and Intensive Treatment, SPIRIT.
Thank you, Lino. Good evening, everyone. It's a great pleasure for me to be here and talk in this beautiful seminar. And I think more than beautiful, it's something extremely important um, for our community, for our lives, how you see patients, how you treat patients, how we treat ourselves, health and disease. So this dichotomy that keeps pushing us to the limits nowadays. And I'm gonna comment on seminar given last year, nearly a year ago, by Dr. David Rosmarin. Um, Obviously, we don't have time to comment on everything. It was a really nice talk for those who had the opportunity to listen to him. It was December last year. So he was talking about new strategies and new approaches to get into those patients, psychiatric patients that come to him and to doctors and ask about God. And this is something that many of you, especially the ones who work in hospitals or deal with patients daily, probably come across, and people asking, especially those that are in deep suffering, asking about God, about spirituality, and what to do. How can we approach this? So I'll ask now our team to play. It's a short part of the talk of the lecture, and then we can discuss a little bit more about it. And I also invite you guys to send questions if you are interested and have any comments on it as well. So we're gonna be seeing your comments on the chat. So please feel free to do so. You can play the video.
Brienne came to me. It was during the lunch break. I was on break. She was on break. She wasn't in session. She was not on my caseload. She was just a patient in the program where I was training. And she came over to me and said, excuse me, can I talk to you about God? So Brienne wanted to discuss her problems, not in psychological terms, but in spiritual terms. And I'm a member of the Orthodox Jewish faith. I wear a yarmulke to work. And I guess this was a cue to her to say that I might be an appropriate person to speak to about her faith. But unfortunately, at the time, I was not the right person at all. I was a trainee. I was there to study cognitive behavior therapy. And although faith was an important part of my personal life, it really wasn't part of my professional life. I mean, that's not entirely true. I had done some research with Ken Pargament beforehand, and I was interested in researching it and studying it. But it was part of my research life. It wasn't part of my clinical life.
So as you guys can appreciate, he brought to our attention something extremely interesting. So imagine yourself in a hospital, in his case in a psychiatric hospital, and patients with suffering a lot with depression, some anxiety, panic disorders, or panic attacks, or schizophrenia. So, all these things happening, and the patient come to you and ask, can I talk to you about God, about religion, about spirituality? So he clearly can see the person is trying to find something that she or he cannot touch at that time. And it's so difficult to deal with this kind of questions, especially here we don't know what to say. So we are so ethical here. There's so many rules we need to follow when you work in a hospital. For example, I work in a hospital, so it's pretty much every 3 months we have a lot of trainings to do to know how to deal with those patients. But what happens if it comes to you? So and during his talk, he clearly mentioned that there would be was a bit uncomfortable to him because he didn't know what to do. He didn't feel like the best person, the right person to answer that woman at that time. But what do? You just leave her alone and say, well, I cannot talk to you about that, or trying to find a priest, try to find um, a religion person that could address this to you. So that it's, it bothered me a lot when I heard that, because in my, it did happen to me. I would immediately try to address that, not in a technical way, but sometimes what those people actually need it's love. They need love. They need some kind of comfort, because it's not easy for them to simply be there suffering. They get in that hospital pretty much the entire day, so being treated. Um, and you see other people around suffering. So what do you do? This is probably what happens also in an oncology, for example. You see those patients that are nearly dying, many of them. And what do you do? So you see yourself in your first day of chemo, for example, and you see another person that are there for several weeks and week, and I'm gonna be like that person. What's going to happen to me? So I'm gonna die. What happens if I die? What happens after life? So then it's where the Spiritism, which is, as Lino mentioned in the beginning, is it's a doctrine. It's Christian. We obviously believe in God, in Jesus, and a lot of other things that trying to explain us what happens to us before you come to this world, and what would happen after you leave this world. And at least for me, it's extremely comfortable to think that there is a future, there is something we can think about, and you can, have faith, but not the type of faith that most of us actually have nowadays. It's like a faith when everything is good, everything is, you're feeling happy, so God is on your side. But then problems happen, and many of us, we just immediately think, oh, God just forgave me, and what would I do? So I think, Sonia, you want to ask something? You're muted.
Sorry. I just occurred to me that this situation is very uncomfortable when, as a clinician or somebody near the patient, is asked that question, and sometimes we're not prepared to answer or to bring any comfort to the patient. And the Jewish Institute for Spirituality and Health is with Dr. Christina Puhalski is conducting a training for clinicians and chaplains together, to work together, to identify the questions and the suffering, especially when it's the spiritual suffering, that they will need the spiritual care, and how clinicians together with chaplains, sometimes the clinician is not completely prepared for that, and they can assess a clinician that works integrated with them to address these questions. I just want to bring this up because many of us through the SMA are taking those trainings, and we intend to bring this training forward to other people. But thank you.
I have a follow-up comment on these that both of you just said. I remember when Dr. Rosmarin, he mentioned that the patient approached him to talk about God and how to, integrate their religious beliefs in the treatment. So he's part of this program where patients spend the whole day there, the resident program, right? So they spend the whole day with the physicians, clinicians, treating them. And this patient had that need to talk about God and to talk about religion and spirituality. And that's, I think, it's a resource that we usually don't explore, right? In most of the hospitals and most of the health systems, we don't talk about, or we don't ask the patients about, their need to talk about spirituality and religion and how that could help in the treatment of many different diseases, if they want to do that. And just one thing that I remember now, and I think that again, it's a resource that we're not exploring. So the Pew Research published a couple of years ago a study on the global landscape of religion in the world, and 84% of the global population they say that they have some sort of religious affiliation. So most of the people living in this planet, they have a connection with some sort of religion. They have spiritual views of their existences, and we are not tapping this resource when we're talking about treatment of diseases. And this is something that, I think all of you agree that we have to explore this more and have to be open to integrate religion and spirituality into the treatment of patients, given that 84%, according to that study, 84% of the global population would probably be open to that.
And Paulo, I think this is precisely the comment that Kirsten Santos has just made.
Right.
She said, I feel that the million-dollar question is how to integrate all of this, if possible, into the creation of a new healthcare policy in paradigm shifts.
I don't think I know the answer.
It's a great question. Yeah, we don't. I honestly don't know the answer. But again, if I knew, I would get $1 million maybe. But yeah, so that's the big point. I mean, it's not people. We are not taking into consideration people's beliefs, people's faith, and this time where they feel they suffer the most, they would definitely need some help. They would benefit from this, absolutely. So we need to definitely consider this, especially those who are dealing with patients in a daily basis. What to do, how to implement this in a hospital, how to bring this to your superiors, how to discuss this kind of thing. And I remember Dr. Rosmarin also mentioned there was when they, he went to his superior and asked about, so what to do, how should I ask them? And his preceptor in the case told, well, you need to find a way to actually deal with this. So he actually wrote it's like a protocol or something that it could be addressed, these things, and he brought to the table to a lot of doctors, and there was a big split. So some of them didn't agree at all, some of them agreed, and the big point is, how can you deal with that? You don't know what type of faith that person has. So if you answer a type of a question that doesn't fulfill what the person needs, what's going to happen? So it's really complex. It's really complex. But I think most of all, if you implement a good service, a good way to deal with that, and especially if you put your feelings and put yourself on that person's shoes, and try to see what if it was you that is asking that question, how would you want to be treated? So, and that's how I think we should approach. So for me, I think it's he also mentioned, you can also go back and see his talk, all the protocol he developed with the residents and all the physicians and everyone involved in this study. So he developed the Spirit, which is like a protocol that could address and meet with those people, address their religion needs. And it was really interesting to see. And another thing it got me really curious and interested. He said that the attendants that were religious, it did worse when dealing with the patients than the ones that did not believe in anything. And he tried to explain in a way why this happened. And in a sense, like in a short, in brief words, is that when you're religion and you try to impose something to a person, so it's not the way things work. So as an example, if a person asks you something and you start to say, well, you must believe in God. If you don't believe in God, you're going to suffer more. So this is not what the person wants to hear, right? So, and the other physician or nurse or any other staff member that would just say, what is your need? What are your needs? So, and then the person said, well, I want to believe in God, and why God forget about me? I actually mentioned forgave, but actually forgot about me. And so, and then it is a way, how can you approach this to the patient in a way that you can, circumvent all the problems this patient or all the questions those patients are asking for. So it's pretty interesting how you think about that. And one thing that I learned from his talk is that you should never impose anything to anyone. So if you're a religion, don't try to, impose your faith to that person, but it's more like they need to be, hugged, loved, in a sense that I like to use, just to finish, that you don't teach anyone religion or spirituality by words. You teach by example. So if they can mirror you in a way, that the way you treat people, the way you're treating him or her, so that would count a lot more than just saying a lot of words that may not mean anything to that person. So I appreciate the time. Thank you so much. I think I went a little bit more than my time, but it was a great discussion.
Thank you, Rafael. Next, I would like to invite Dr. Livia Uehara to talk about Dr. Elaine Drysdale's webinar, Spirituality in Guiding Clinical Practice in Mental Health Care.
Thank you so much, Lino. Good evening, everyone. It's a pleasure to be here tonight. I have to thank Dr. Rafael Rezende. He helped me a lot in the things that he shared with us. Tonight, we are going to share some enlightenments that we had with Dr. Elaine Drysdale. Most of her professional experiences related to patients in the end of life. That is the reason we are going to most discuss about it. So she brought a lot of real stories of patients to us, where the biological explanation, we have some theories. She also talked about the theories in medicine. So we are progressing, also answering interesting questions. So the paradigm in medicine is changing. It's not in the speed that we would like to have, but still is changing. So initially we had the biological explanation according with Dr. Drysdale lecture. So biological problems and biological responses. However, that model cannot help patients with questions, with life-threatening diseases or in the end of the life. They are afraid of dying. They're afraid of what they don't know. They are afraid to go to the hell. According to the faith, they could have different backgrounds in religion or even do not have any kind of religion. So how to cope with that process of dying? So she also explained the progression in the 60s for the mind-body process, the dualism, is still not completely explained because there are a lot of theories. I will not go over those explanations, but we will use one of them that Dr. Drysdale brought. I can share, if any of you want later, some explanation about the 6 theories that we have related to mind-body correlation. And the one that she used to have is most related to the near-death experience. I'm going to ask her to share 2 short videos, and then I'll go over more explanation about the lecture.
When we look at end-of-life issues, major themes that I've come across are fear of abandonment by God or people, isolation, fear of the unknown is a big one. Wanting to be in control of the future is a very big one, and I think plays a big role in requests for medical assistance in dying. Then there are anger and fears about imminent death, in addition to grief about life ending. So those are some of the questions that you can ask to get a sense of what might be helpful to the person. But if the patient is nauseated or in pain or dying, sometimes it's too much effort to go through that for the patient, and I cut to the chase. And I just ask, do you believe in a spiritual realm or in God or higher power? Do you believe in an afterlife? Those questions are simple, but useful to provide support, especially if the patient has a life-threatening illness. It sounds obvious, but these questions are often missed or considered to be too private, which seems to me to be a bit crazy when the patient is facing a life-threatening situation. But sometimes health professionals just don't know how to respond. But you don't need to be a chaplain or a part.
The comments that I have here, we need to be sure that not all healthcare professionals, they're really trained on it. So Rafael has already mentioned that. So we need to increase the awareness of spirituality in the treatment of patients. And it's not related to religion, but spirituality, connection with a higher power, whatever it is for the patient. To consider a tailored approach for each patient. We cannot treat all the patients like a policy in the same way. We need to see each patient's needs, stay together, listen to them. Because the other thing that is forbidden in the US is we cannot practice proselytism. We cannot force the patients to believe in our beliefs, as Rafael has mentioned. So it's even tougher for the physicians that have faith to listen to the other and to open their hearts for a different faith. So we need to pay attention to that, because there are a lot of hospitals, they forbid to make the proselytism. One of the tools that Dr. Drysdale is using is the knowledge that we have in near-death experience. We have a lot of publications on it, a lot of books. I have also the books that she mentioned. If anyone wants to know the books that she mentioned about different topics that she discussed, I have all the names to share with you all. So all the patients that had the opportunity to have a near-death experience that could vary according to men, women, or children, okay, but what most of them, they have in common is so often includes a sense of awareness of being dead or medically unconscious, feeling of very comfortable and free of pain, and a great peace. Sensation of leaving the body, sometimes being able to see the physical body while floating above. They usually pass to a bright light, sometimes to a dark tunnel, and feel the light as welcoming them. The mind functioning more clearly and more rapidly than usual. So that good experience that those patients describe after coming back is one of the tools that she is using to share for the patients that are in fear to die. What is going to happen afterwards? I don't know. I'm afraid to go to hell because we cannot push our knowledge or our faith in for them. So this is a way that she used to bring that. But there are some patients that are atheists. One of her patients told, nobody's going to convince me in my bed of that I'm going to be in this or that place. So also for that patient specifically, she considered to bring patients' experience, what she made of importance in her life, the good moments that she had with family, the good experience. So we need to tailor for each patient that we have. The last, can you please play the other video?
Energy. But we know that when people are dying or in the last sometimes year of their life, it's not just in the last hour or two, it can maybe be months before, that focal point seems to soften again, and they may be more able to see a spiritual realm. Now, Dr. Jeff O'Driscoll is an emergency physician, and he worked in emergency for many years, and was able to see sometimes the spirits of patients who were not able to be resuscitated in emergency. And he has come out about this and written a book called Not Yet. And he talks about the veil, and he says it's as if there's a curtain and that it parts when newborns come from that spiritual realm more and into the physical realm, and it parts again when people are leaving. And that the light of glory is more visible as that curtain is opening. And it seems to me that it's more visible perhaps to people nearby physically, or perhaps.
So another point that she mentioned is all of us, we work in hospitals. We have heard in some moments of our experience that most of those patients that are dying, they start to see dead people. They have those bad visions. So one of the things, there is a book, a very interesting book from Dr. Peter Fenwick, The Art of Dying. He describes there, most of those patients, they have in common some characteristics. They do not lose their conscious. They are really focusing a point. So I will not describe right that, but that sense of the presence of family members that are deceased that come to say, I'm here, I'm waiting for you, like a kind of preparation for those patients that are close to die. So in most of those patients, they have that good sensation. So we cannot deny, but what happens is the healthcare professionals usually they ignore that because they don't know how to deal. So as I don't know, I ignore. So that it's really important, even that you do not accept or whatever is your face, that you are aware of that. How can you help your patient to manage that and to walk through that? And one of the characteristics that Dr. Fenwick mentioned is all the people that see people die, deceased people, all witnesses agree they take place in real space, often at the moment of death. The nurse or relative who is with the dying patient notes that the patient look fixed at a particular corner or stretch a hand like to reach the person who has come to pick them up. So we need to be aware of that and know how to manage that. So it's really important. How can we make the difference as a healthcare professional, or even if you are not a healthcare professional, you don't need to be. If you are aware of those things and stay together with your family member who is dying, how can you support? And that's how can I support you? Can I bring someone that has more knowledge to support you and to give that hope to you? I don't know if I still have time. One of the last comment that I'd like to, it's really important, it's related to the non-local consciousness, because a lot of discussions about that, but related after the near-death experience, we have that knowledge growing, that the brain, our brain is like our brain is the hardware, and our consciousness would be the software. That is the reason why when the patients, they have that near-death experience, they can describe exactly everything. For example, if they are in a surgery, open heart surgery, and they can describe the conversation, everything was happening, even that the cortex is not working. So this is one of the concepts that she used more to help those patients to understand that we are more than our physical body. And I put that together with the principles of the Spiritism that Lino has already shared with you. So the existence of a supreme intelligence helping those patients, right, to understand if there is something bigger than me, can give me some kind of hope of the existence of immortality of the soul that we call incarnated spirit. So we say that the spiritual world is the original world, is pre-existence to the life that we have and surviving afterlife. So that feeling, I personally feel very supported by that option that I have to believe that something else is waiting for me. Also in the reincarnation that we have, or polygenesis, if you want a more scientific expression, that we have that possibility to die, to find our family members, to have that comfort that we are not alone, that we are going to be supported. So in the middle of the lecture, one of the things that she was really emotional during a moment, touched emotionally, and even with some drops flowing, when she told us that before giving a support to a patient, she asks support for a higher power, And she was really, emotionally touched. And I was as well, because I could feel how that connection with patients, to support them, to give that hope to them that there is something else, to comfort them. This is what I have to discuss tonight. If you guys have any other comments, I would appreciate, or questions.
Thank you very much, Livia, for this great review. And we have a question here in the chat, but I will reserve that question for the end when we have all the panelists together. But for now, I'm gonna invite Dr. Paulo Bispo to share his views on the webinar with Dr. Alexander Moreira-Almeida, entitled "Integrating Spirituality in the Prevention and Treatment of Alcohol and Other Substance Use Disorders."
Great, thanks, Lino. So Dr. Almeida, he developed these guidelines for integrating spirituality into the treatment of patients with alcohol and other substance use disorders. He's a psychiatrist from Brazil, so he treats those patients in his clinic and hospital service as well. And what they did was to create some sort of protocol or a guideline where, and that was actually supported by the Brazilian Association of Psychiatrists as well, to sort of create a framework for psychiatrists in the country to use that model to treat their patients. And that is a model that integrates a couple of different dimensions. We're going to discuss these later, of our existence, of the dimensions of a human being, including spirituality. So the rationale for him to do that, he builds that rationale in his talk, and he mentions that study that I mentioned before from Pew Research, showing that 84% of the global population have some sort of type of religious affiliation. And he also mentions a lot of previous work that was done by many different groups, including his group, on the positive impact of integrating spirituality in the treatment of many mental disorders, not only a substance use disorder, a lot of other mental illnesses as well. And he did a lot of work with alcohol and other substance use disorder, including these, integrating spirituality and religion in the treatment. So if spirituality can help in the treatment of these patients with substance use disorder, and most of the global population has some relationship with spirituality, then this is a resource, as I mentioned before, that needs to be explored and integrated into the treatment of patients with many types of different mental problems, mental disorders, including substance use disorder. So his approach, as I mentioned before, to integrate spirituality into the treatment of these patients is based on a model that actually integrates multiple dimensions of a human being or of one's existence. So that includes the biological factors, the social dimension, the psychological dimension, which is in line, by the way, with the WHO's definition of health. If you all remember, the definition of health from the World Health Organization is a state of complete physical, mental, and social well-being, and not merely the absence of disease or any other illnesses. So that framework from the WHO's definition of health is here in this model, as it is in all the psychosomatic medicine research that is being done, showing a lot of interesting results. And what he did here was to include the fourth dimension that was missing here, which is spirituality and religion, right? So he then explains his biopsychosocial spiritual approach, and he goes first over the underlying mechanisms that could be related to each of these different dimensions in patients with substance use disorder. So when he mentions the biological factors, for example, he talks about genetic predispositions, innate tolerance, for example, to a specific concentration of drugs, which usually results in people having to use more and more and more of that particular substance and lead to abuse and addiction. Psychological factors, of course, like impulsivity, novelty seeking, low self-esteem, and other actually mental health disorders that could lead to the need to use some sort of substance to numb the feelings, the emotions, and get through that particular difficult period of their lives. Social living in an environment where substance use is common, for example, that is one of the underlying mechanisms that could be associated with substance use disorder in that social dimension. And then the spiritual. So the spiritual, he talks about the loss of existential meaning regarding oneself as a sinner, for example, or that the person was being banished by God because that they see themselves as sinners. So these are the problems associated with each of these dimensions, and then he dives into the approach, what to do in terms of integrating all of these different dimensions into the treatment of these patients, and what needs to be done in each of those dimensions. So let's take a look at the video and go over this specific part of his talk.
Approach, using approach for all these dimensions. This is very, very important. We need to remember or to remind physicians, for example, that cannot pay attention only in the biological aspects. We need to remind psychologists that we cannot pay attention only to psychological aspects, or to the religious groups that we cannot pay attention only to religious spiritual aspects. But we need and must integrate everything in the best interest of the patient. So for example, some examples of this integration. Biological aspects, we can, when required, using medication, for example, to treat depression or to treat alcohol withdrawal symptoms and things like that. A healthy diet, practicing physical activity. All of these are interventions in biological aspect of individual. Psychological interventions, psychotherapy, psychoeducation. Social interventions, encouragement of improving and increasing the relationship with family, with other social contacts, health leisure activities. So these are some examples of social interventions. And the spiritual intervention, supporting the use of positive religious spiritual resources that the patient may possess. So the patient and the professionals do not need to choose between these interventions. It will be much more interesting if we sum this intervention. They can integrate and potentialize each other. So this is very important.
So that's interesting. And again, I think, the model that he's using, a lot of these has been developed before because it's sort of the framework for psychosomatic medicine. And so there is the integration of these three different dimensions, the first three different dimensions, biological, psychological, and social. And then, of course, in psychosomatic medicine, there is a strong focus on, the biological intersection points that sort of connect social stresses with psychological stresses as well, including the brain, endocrine system, and immune system. So I think, what he's doing here is to, as I mentioned before, he's including that fourth part, the spiritual and religion dimension of one's existence into the treatment as well. So for the first three, I think, there's a lot of studies published showing that, there is a positive impact when these different dimensions of our existences, they are integrated into the first, the understanding of disease, and then how to intervene and treat those diseases as well. So let's take a look now. The next video, he's going to dive into the specific part where he goes into the spiritual and religious intervention.
Exploring potential useful spiritual research. I said about religious reading religious spiritual texts, cognitive framework also. The idea, for example, that life has a meaning, that if I'm facing a stressful situation, I have the resources to cope with it. For example, if God is good, if God is just, if something is happening to me, there is a reason, there is usually a positive reason, there is a lesson to be learned, and also that God would never make me to face or to cope with a situation that is beyond my strengths. So if I'm facing something, I can handle it in some way. I can seek help, and this help can be, for example, in the community, the religious community, could be through prayer. And another very positive religious framework is, for example, that instead of thinking that I'm omnipotent, that I have the control of everything in my life, this is one extreme. There is the other extreme, negative extreme also, is that I have no control in my life. God or my karma of past life or God or obsessing spirits are causing all of my problems and I can do nothing. So a very intermediary strategy is a collaborative coping with God, in the sense that I do whatever I can, I do the best I can to solve the problem, and the rest I trust in God. So I cannot do everything by myself, but I cannot defer everything to God or spirits or whatever. So this kind of partnership with God or with the spiritual entities could be very useful. So listen to or watching religion and spiritual programs, okay, and community service, attending religious services, as we had discussed previously, okay?
So, in the guideline actually has like a nice flow chart on how to go through the model when seeing a patient and treating the patient. And of course, it starts with taking a history, right? So when you take the history of the patient, then you can understand what is going to be the biological needs, the psychological needs, and the social needs for the patients, and prescribe the interventions on those dimensions. So here he's talking about the fourth part now, which is the spiritual and religion. And then he goes over, a couple of different points there on how they approach the patients. So when they're taking the history of the patients, it's very interesting because they have, the paper is published, by the way, in the Brazilian Journal of Psychiatry, and the whole guideline is there. So when they take the history of the patient, they take the spiritual history as well, which is something that we usually don't do, right, in medicine. So they include that part when they're taking the history, and they, of course, approach that in a way that they they make sure that the patients are free to talk about the religions if they want to talk about the spirituality if they want to. He came across to me as being very sensitive to different cultures, to being very sensitive to different religions. And I think that, it should be in general an approach of any human being to anything to be sensitive about differences in culture, including in religion. And that is probably even more important when you are treating patients as a physician. And that is part of the first point there of, taking the spiritual history in a very sensitive way, that you make sure that the patients are comfortable and free to talk about their spiritual views or their religions. And then based on this, they're going to tailor the treatment. So the spiritual approach, like the readings, prayers, meditations, community service that they're going to recommend is going to be based on each patient and each patient's views about spirituality, each patient's religion. So after these, any comments, by the way, about these or questions? Nope. So after this, he talks about the positive effects on the patients. And in this case, in patients with alcohol and other substance abuse disorder. And there's a lot of positive effects, positive coping and positive effects in terms of not, first stopping the use of that particular drug. And then the other positive effect is the number of people who go back to use those drugs again. So the positive effects were very interesting there. But during the discussion, I actually asked him about the negative effects, if they exist or not, if negative effects could happen while integrating spirituality in the treatment of these patients. And, I asked this because I was thinking about the possibility of having patients with a passive attitude, with this transfer of responsibility to God. And the final parts of the video that we just watched, he talks about, how he discussed with the patient this idea of having a partnership with God, which is very interesting. Having a partnership with God during the treatment of my disease in a way that, it's a partnership. I need to do what I need to do, and I'm going to also rely on the supreme power and this higher power to help me, but without transfer of responsibility. And that's something that was very interesting that he mentioned. And I think I wanted to discuss this as the final portion of my summary here, because I think that is probably important for clinicians considering this type of interventions to treat their patients, because the negative effects could happen. And one of them, when he discusses that, is the fact that sometimes the views of some spiritual leaders, for example, or leaders of their church, could be a little bit conflicting with the treatment of the patient, right? And when that happens, that passive attitude could happen with the patient, or that transfer of responsibility. I don't need to do anything because the leader of my church or the leader of my spiritual group is taking care of me. So that partnership that he talks about with God or with someone who you trust is no longer there because the patient is not doing their part. And then he mentions that it's part of their guideline to actually work in this two-way approach where they're treating the patients in the hospital, but they want to be involved with their religious community. So to do that, again, they seem to be very sensitive about, differences in religion, differences in culture. They discuss that with the patients first. So they ask the patients, especially with those patients when they identify conflicting views that could have, negative effects in their treatment. Can I talk to your mentor, to your spiritual guide, to the leader of your church to discuss your treatment? And he mentions that, in most cases, the patients say, okay, you can do that. And in most cases, they have a positive response from the spiritual leaders as well, in terms of, we need to have a partnership here, including the person who's being treated right now, and we need to work together. Some of the views sometimes that could be interfering, for example, with medications, which could be a problem. They discuss that with the spiritual leader so they can go back to prescribing the medications and making sure that the patients are going to use. So I wanted to mention this because that was actually a very good chunk of our discussion, and I think that is important for clinicians considering to do that, because most of the times the effects are positive, but in some cases, depending on how the patient approach the spirituality and the religion in their treatment, it could actually be problematic, but there are ways of overcoming the problems. Then, just to summarize, we talked about these before, about, exploring these that can be a resource actually to the treatment of the patients. That idea that there is a spiritual realm, or that, that life doesn't end here. If the patients have that idea as well, if they have some sort of spiritual ideas, that can be a resource to be explored. And I think we need to tap into this. So he summarized his talk saying this: in respect to the evidence available and to the religious and the spiritual beliefs, behaviors, and values of most of the world's population, it's not only appropriate, but a scientific and ethical responsibility to integrate religion and spirituality in clinical care. So with that, I think we can either start a discussion now or later. And Lino.
Thank you, Paulo, very much. There's a question for you, but I think I'll invite now Dr. Sonia Doi to cover the webinar of Dr. Harold Koenig about religion, spirituality, and mental health, research and clinical applications. And we can leave the question that was directed to when we finish for the panel.
Thank you very much, Lino. In his webinar, Dr. Koenig showed an impressive amount of data to support the benefits of spiritual or religious involvement on physical, social, and mental health. But I selected one segment of his talk to discuss as to what extent religious or spiritual involvement impact our lives. So I would like to ask our team to play the segment of the video.
Now, here's a model that helps to explain why religious involvement is related to better mental and social health. And it really doesn't take a rocket scientist to figure out why this might not be the case, why this might be the case. This is a model that's out of the 3rd edition of the handbook that is coming out later this year. But religious involvement, particularly religious involvement, attending religious services, praying to God, studying the scriptures, volunteering for religious reasons, getting a religious education, and being more devout in one's religious practices, and using religion to cope with stress. All of that seems to affect the person's mental and social health across their lifespan, beginning literally even before conception. Now, can you believe that? Even before conception, it appears that the religious behavior of parents affects the quality of the sperm and the ovum. And then once they come together with conception, then the behavior of the mother, the beliefs and the behavior of the mother, religious beliefs and behavior of the mother, then affects the health of the ovum as it grows within the uterus. And this all stands to reason because, religious people don't drink as much alcohol, they don't use as much drugs, they're less stressed, they have less depression, they're more likely to have a spouse and more support. That's all going to create a healthier intrauterine environment for that fetus to grow.
There are 2 parts in this segment that I'd like to touch and discuss. Dr. Koenig highlighted the fact that religious commitment or religious involvement impact our social and mental health across our entire life, and he stresses beginning even before conception. He further explains why he thinks that happens, and I particularly asked him, how does this happen? And I was interested in whether there is any research to show that religious commitment affects the reproductive cells. Dr. Koenig responded that this is implied from data showing that the effect of religion, has on changing the unhealthy behavior to healthier behavior, for example, alcohol use or drug abuse, that may adversely affect these cells. And when one is more involved in religious practices, they will then turn into a better behavior, and then there is a benefit over these cells. So that's how he thinks it's reflected on reproductive cells. I also thought about scientific research, especially those on the studies on psychoneuroendoimmunology that have demonstrated that our emotions, our thoughts, our mental state overall affects the body, our body function, especially the biology of every cell in our body. And that would include, of course, reproductive cells. So I think that would be another explanation. But so on top of the change of behaviors, I think that we could consider also that specific effect of our mental state, of thoughts, as a effect, impact on the cell biology. But I also would like to expand a little bit on this discussion. If we consider that since the moment of conception, there is a spirit that is linked to the embryo, and that this spirit of the unborn child is susceptible to the mother's energy field, we can now look at the influence of religion and spirituality from another angle. And I would like any of my colleagues to intervene, but if they want to enter this discussion further. But there's a vast literature on the consciousness of the unborn child. And I'd like to cite, for example, the book Windows to the Womb by Dr. David Chamberlain, that describes many interesting cases of perception of uterine and extrauterine environment by the unborn baby. So overall, the scientific research data cited by Dr. Koenig and this literature on the perceptions of the unborn child fully corroborate the revelations of enlightened spirits through their messages published in Spiritist books, messages that are written by psychography or automatic writing. So there's a large, vast literature that is corroborated by all this scientific data, talking about the effect of the mind, the state of the mind, the thoughts that we believe are not in the part of the brain, as was discussed earlier, but is in the extracorporeal part. And we would like to say the spirit, if you will. And that can affect the entire body. Through the Spiritist perspective, it's easy to understand that the mother, because Dr. Koenig also mentions about the mother when during pregnancy, that the mother who is involved in religious and spiritual practices maintain a good environment, intrauterine environment for the baby to develop and to grow. So through the Spiritist perspective, we also understand that the mother, and sometimes both parents, being engaged in religious, spiritual practices will maintain a closer connection with the divine. And that their elevated mental state will attract good, like minds, good people among living persons or good spirits from the spirit world, creating a beneficial environment, not only for the mother, but also for the baby, the unborn child. So I'd like to see if any of my colleagues would like to further make any comments to this part. No? Okay. So I will then wait for any questions from the audience, but I find really amazing how Dr. Koenig combines his prolific research on spirituality, religion, and health, his experience as a clinician and as a teacher, and also his strong personal faith, personal belief. I find that really, really interesting. Throughout his talk, he emphasized that faith in God is really important, not only to maintain our mental health, but also in the education of our children and our youth, to guide them through a more through a healthier behavior in life. So I think I am almost out of time here, and I'd like to just leave more time for discussion. So thank you.
Thank you very much, Sonia. Thank you, Rafael, Livia, Paulo, and Sonia for these great remarks. We have some questions from the audience, and we should have some time for discussion. So the first question from Kirsten dos Santos is, I think, to all panelists, do any of the panel participants practice in the United States?
Nope.
I think we all work here. I don't practice, I do research, so I don't see patients.
Yeah, same here, research. There's another comment here from Ulrich Hoboken. Good evening to all. Dr. Uehara, I recently experienced some of my family passing differently than many places. I was allowed to remain in the ICU for most of the day, even allowed to stay overnight. And I noticed that doctors were pretty much prying that I knew from the patient in order to take action for next steps. Perhaps praying. Despite of the hospital having a dedicated psychological team, they were always asking me about the topic of, is the patient ready to address death now? I felt overwhelmed by the fact that they are waiting on me to talk to the patient. Perhaps you want to comment on that talk from Dr. Drysdale on how difficult it is to bridge that gap, with the for most clinicians that are not, used to addressing spiritual reality, especially terminally ill patients.
So can I comment now, Lino? First of all, I'm so sorry for your family member who reached. I hope you now, even that afterwards, you have the support you need, because the other point that we need to pay attention is not only to the patient, but to the family members. And although I'm not practicing in US, but I have a lot of, recently, I don't know what is happening, some family members looking for my help because of the previous experience I have with terminal patients because of my specialty. Many patients that die with me, and I always supported the families not here in US. But this is something that when we have a illness, a diagnosis, which we foresee that the treatment is going to be short or the patient lifetime is not going to be large, we need to start to talk with the patient even before and with the family members. This is really important, but it's not what usually happens. Not only here in US, I would say in many countries, and even in my previous experience, most of the time we have some policies in healthcare system that the physician doesn't have. I'm not justifying, but the short period of time, the number of patients in the system with more papers, and the patient has short time. This is not an explanation, but it's the fact, what we see. Okay, if you have the chance to talk to someone, a psychologist or a chaplain or someone that could help you now, I don't know if it's going to help you, but it's really important. Go in your face, whatever you practice, to have that emotional support to help you right now. If any of my colleagues has any other comment on it.
Thank you, Livia. There's another question for Dr. Bispo here, and it's from Elisa Glass, and she says, it is fascinating, Dr. Bispo. Do you think that there must be an educational component for doctors to address spirituality? I believe most are uncomfortable and not in their scope of practice. I have seen many angry patients.
Definitely. I think we need to normalize spiritual care in healthcare systems, so that everyone feels comfortable about talking about spiritual care, and including that in education, I think is fundamental. Not only to normalize it, but so that the future physicians, they actually know how to take a spiritual history, for example, or how to talk about the differences between religion and spirituality, and help some patients that sometimes they don't have any specific religion affiliation and they don't want to have, but they are interested in talking about spirituality, in talking about what happens after we die, in talking about their views of what happens after we die. So I think that is fundamental, and that is going to help us normalize spiritual care in healthcare systems. I've had a bunch of colleagues, especially psychiatrists, approach me to talk about this, that they were very uncomfortable to talk about spiritual care, even when their patients kind of approach them to ask about, can we talk about God? Can we talk about my religion? And maybe, find ways to help me during my treatment, because they fear sometimes retaliation actually of their programs, especially young physicians who are still under training. They don't know if their programs are going to accept that or not, especially leadership. Because that idea of approaching spirituality as a tool during the treatment of patient is not, in many cases, not normalized, but it's changing. So if you go on PubMed and you search spiritual care or spiritual training in medical school, you're going to find a lot of papers, and you're going to find a lot of systematic reviews. I just found one when I saw your question. It was published by a group of physicians from the Cleveland Clinic in Ohio. It was a systematic review about spiritual care in medical training in US specifically. And they talk about, details in the curriculum, for example. They found that, in some medical schools, it's actually mandatory to have training in spiritual care. In others, it's still an elective class, but it's there, and the students can choose to attend that class. And then they talk a little bit about the curriculum and things like, learning how to take a spiritual history is there, delineating differences between spirituality and religion, so we can help more people, even those that are not associated with any religion, and other things. So that is happening, and a lot of medical schools are incorporating that now in the training of students.
All right, thank you so much, Dr. Bispo. Any other comments from the panel? Any other remarks before we do our final remarks? So if not, I would like to thank the panelists for their very engaging, enlightening discussion, and also to thank everyone who joined us online tonight for this webinar on spirituality and mental health from the Spiritist Medical Association. I wish you all a good night, and may God bless you.
Thank you. Have a good
Good night.
Have a good night.